My name's Roger Henderson. I'm a GP and I also co-host the GP Notebook study groups. Welcome to the GP Notebook podcast, where we discuss bite-sized topics aimed at all those working in primary care. Now, in this episode, I'm going to be discussing gastric cancer, a malignancy that's quietly shifted its face over the last several decades and yet continues to exact a heavy global toll. Now, whilst its incidence has declined in many high-income countries, gastric cancer still remains one of the leading causes of cancer mortality worldwide, particularly in low-resource settings. And what makes this disease especially sobering is that many of the deaths we see are not due to a lack of treatment options, but rather to delayed diagnosis and aggressive tumour biology. So from a global perspective, gastric cancer is anything but evenly distributed. It's the fourth leading cause of cancer deaths worldwide and the fifth most frequently diagnosed cancer. The rates remain highest in East Asia, Eastern Europe and parts of South America. And in countries like Japan and South Korea, population-based endoscopic screening has fundamentally altered the natural history of this disease. Early-stage cancers are commonly detected and treated endoscopically, leading to markedly improved survival. Whereas in contrast, in Western countries where routine screening is uncommon, gastric cancer, as we all know, remains a disease that can often announce itself late, often after it has already spread beyond the stomach. Now, here in the UK, there are around 6,600 new stomach cancer cases every year, and it's the 18th most common cancer in this country, accounting for 2% of all new cancer cases. And the incidence rates for stomach cancer here in the UK are highest in people aged 85 to 89. And each year, half of all new stomach cancer cases are diagnosed in people aged over 75. Now, since the early 1990s, stomach cancer incidence rates have decreased by 55% in the UK and are projected to fall by a further 12% here between 2025 and 2040, which is obviously welcome news. But understanding why gastric cancer develops requires us to look beyond a single cause, and most cases are sporadic, but a meaningful subset does arise in the context of inherited cancer syndromes. So conditions such as hereditary diffuse gastric cancer, Lynch syndrome, familial adenomatous polyposis, and Peutz-Jeghers syndrome all significantly elevate the lifetime risk. And these patients challenge us not only diagnostically, but also ethically, as risk-reducing strategies, including prophylactic gastrectomy, may need to be discussed long before cancer develops. Still, the dominant driver of gastric carcinogenesis worldwide remains chronic infection with Helicobacter pylori. This organism initiates a cascade of chronic inflammation that can, over years or decades, transform normal gastric mucosa into dysplasia and then invasive cancer. And yet, H. pylori alone does not seal a patient's fate. Host genetics, their immune response, bacterial virulence factors, diet, smoking, and environmental exposures all interact in ways we are only beginning to start to understand. Now, as you'll know, dietary patterns have long been implicated, particularly the high consumption of salt-preserved and smoked foods, which promote mucosal damage and carcinogen formation. Smoking increases gastric cancer risk in a dose-dependent fashion, and obesity appears to selectively raise the risk of proximal gastric and gastroesophageal junction tumours. Chronic gastroesophageal reflux, especially when associated with bile reflux after gastric surgery, further contributes to malignant transformation in the proximal stomach. And of course, host-related conditions also matter. So chronic atrophic gastritis, pernicious anemia, and previous gastric ulcers can all create a mucosal environment that favours intestinal-type carcinogenesis, and even something as seemingly unrelated as our blood type can play a role here, with type A blood associated with a modestly increased risk, particularly of diffuse-type cancers. On the other end of the spectrum, though, diets rich in fresh fruits, vegetables, and fibre do appear to offer some protective benefit, reinforcing the role of lifestyle in modulating risk. Now, histologically, gastric cancer is most commonly discussed through the lens of the Lauren classification, which divides tumours into intestinal and diffuse types. So, intestinal type cancers tend to form glands, resemble colorectal adenocarcinomas, and often follow a well-defined precancerous pathway. Diffuse type cancers, in contrast, are characterized by a loss of cell cohesion, frequently due to defects in adhesion molecules such as E-cadherin. And these tumours infiltrate the stomach wall insidiously, often without forming a discrete mass, and this can lead to the classic linitis plastica phenotype, a stiff, non-distensible stomach that may appear deceptively normal on a superficial inspection. Now, in recent years, molecular classification has added a new dimension to our understanding, and gastric cancers can now be grouped based on genomic and epigenetic factors, including Epstein-Barr virus-associated tumours, microsatellite unstable tumours, chromosomally unstable tumours, and genomically stable cancers. These categories correlate imperfectly with histology, but do provide valuable prognostic and therapeutic insight. HER2 amplification, for example, identifies patients who may benefit from targeted therapy, while microsatellite instability predicts the responsiveness to immune checkpoint inhibitors. Now, despite all these advances in biology, the clinical presentation of gastric cancer to us as GPs remains frustratingly non-specific. An early disease often masquerades as benign dyspepsia, postprandial fullness, epigastric discomfort, or bloating would be typical here. Patients and clinicians alike may attribute these symptoms to gastritis, reflux, or even functional disorders, and by the time alarm features such as weight loss, anemia, persistent vomiting, or overt gastrointestinal bleeding appear, the disease is then frequently advanced. In early disease, physical examination is rarely revealing, but when present, findings such as a palpable abdominal mass, ascites, or metastatic lymphadenopathy, particularly a left supraclavicular node here, often signal widespread involvement. Peritoneal metastases may manifest as ovarian masses, periumbilical nodules, or bowel obstruction, underscoring the aggressive nature of advanced disease. Now, as we said earlier, endoscopy does remain the cornerstone of diagnosis. This allows not only visualization, but histological confirmation through biopsy, which is essential given the variable appearance of gastric lesions. Adequate sampling simply cannot be overstated here. Multiple biopsies dramatically improve the diagnostic yield, especially for ulcerative or infiltrative lesions. Advanced endoscopic techniques, including narrowband imaging and chromoendoscopy, can also help identify subtle mucosal abnormalities that might otherwise be missed. Now, once we've identified this cancer, staging becomes the next critical step. An endoscopic ultrasound provides valuable information about the depth of invasion and regional lymph nodes and guides decisions about endoscopic versus surgical management. Cross-sectional imaging does help evaluate for distant disease, but its limitations, particularly in detecting peritoneal spread, for example, must be acknowledged. And diagnostic laparoscopy with peritoneal washings has therefore become an essential part of staging for potentially resectable disease, often now altering management in a substantial proportion of our patients. And the treatment of gastric cancer has evolved into a truly multimodal endeavour in 2026. For a select group of patients with very early disease, endoscopic resection offers a curative, organ-preserving option with excellent long-term outcomes. But unfortunately for most patients, surgery remains central, and it's increasingly performed in conjunction with systemic therapy. Perioperative chemotherapy has transformed outcomes in locally advanced disease by improving resectability and addressing micrometastatic spread early. And modern regimes have demonstrated clear survival advantages over surgery alone, and these also provide a window into tumour biology. So patients who progress during preoperative therapy may be spared non-beneficial surgery here. The surgical technique itself is also critical. Adequate margins and comprehensive lymph node dissection are essential for both local control and accurate staging. Now, whilst extensive lymphadenectomy was once associated with significant morbidity, refinements in technique and perioperative care have made it safer in experienced centres. Minimally invasive approaches are increasingly common now and, in selected patients, do offer comparable oncologic outcomes with faster recovery. If we look at the role of radiation therapy, this has narrowed over time. While earlier studies supported its use after surgery, particularly when lymph node dissection was limited, more recent trials now suggest little benefit when high-quality surgery and effective chemotherapy are delivered. So today, radiation is generally reserved for specific scenarios, such as inadequate resection, intolerance to chemotherapy, or palliation of local symptoms. In metastatic gastric cancer disease, the focus shifts towards palliation and life extension. Combination chemotherapy does improve survival and symptom control, though the gains remain modest. Biomarker testing is now standard, as targeted therapies and immunotherapy have opened up new avenues for select patients. HER2 positive tumours benefit from targeted antibodies, and immune checkpoint inhibitors have shown durable responses in subsets defined by their molecular features. And looking at very new treatments here, NICE has now recommended pembrolizumab as an option for treating tumours with high microsatellite instability or mismatch repair deficiency in adults with unresectable or metastatic gastric cancer that has progressed during or after having one therapy. But this must be stopped at 2 years of uninterrupted treatment or earlier if the cancer has progressed. NICE has also recommended trifluridine tipiracil as an option for treating metastatic gastric cancer or gastroesophageal junction adenocarcinoma in adults who have had 2 or more treatment regimes. And it has been shown that people using this medication live longer compared to best supportive care. Now, currently, there are no curative treatments for HER2 negative, advanced or metastatic gastric, gastroesophageal junction, or esophageal adenocarcinoma. Even with these advances, gastric cancer remains a disease with a sobering prognosis, although survival has almost tripled in the last 50 years in the UK, and 16% of people diagnosed with stomach cancer in England now survive their disease for 10 years or more. However, unfortunately, the 5-year relative survival for stomach cancer is still below the European average here in the UK. Early detection dramatically improves outcomes, yet most of our patients with the condition continue to present late to us. And I believe this reality now challenges us to think more critically about risk stratification, surveillance in high-risk populations, and the broader role of prevention, including H. pylori eradication and lifestyle modification. So that's a quick overview of this very big topic of gastric cancer, and I do hope you found the podcast helpful. But have a look at the show notes that accompany this episode at GPnotebook.com, and we'd be very grateful if you'd consider following the podcast and leaving us a review on your favourite podcast platform. Do feel free to get in touch via social media at GPnotebook or email us support@GPnotebook.com if you have any questions, comments, or ideas for future podcasts. You should also visit us at GPnotebook.com to register for our virtual GP Notebook study groups, which occur all year round, and to download free shortcuts to help improve the lives of our patients in primary care. But, as always, until the next time, thank you for listening, and goodbye.